Well, really lovely to see everyone this evening, and thank you very much to all of you for joining. So I'm really looking forward to some interesting discussions this evening. My name is Sue Broster. I'm a neonatologist in Cambridge and one of the deputy medical directors here. You will notice that I am not... Namu, did you want to come in?
Yeah, sorry, Sue, we cannot see you. Your camera has just gone dark.
Oh, I can see myself on my screen.
Oh, could you just turn it off and turn it back on again, please? Sometimes there's a bit of glitch, but yeah, now we can see you. Thank you.
So sorry for that. So as I was just saying, so many of you will notice as a neonatologist, I'm absolutely not a surgeon. So I'm really delighted to host this event and looking forward to a fascinating evening and actually learning a lot myself from hearing from the teams involved in what is now the 5th series of surgeons and another extremely interesting and fascinating series to watch. So I just want to say thank you to all of our panelists for joining. I'm just going to let them introduce themselves, and then we'll get into the questions, and I'll talk through how you can do that for the session today. So Magda, can I introduce you first?
Hello everyone, my name is Magda Smith. I'm one of the neuroanesthetic consultants. I completed my anesthesia training in Bristol in Severn Deanery and then moved to Addenbrooke's 5 years ago. And I've been a consultant here for 5 years now. I mostly anesthetize patients for spinal and neurosurgical procedures. I'm also an audit and quality improvement lead in the neuroanesthesia. I was involved in 3 of the episodes in the last series. Hopefully we'll talk about some of them.
Thanks very much, Magda. Adrian.
Hello, I'm Adrian Ball. I'm an emergency doctor. I work in the A&E department of Addenbrooke's and I've been there since 2005. And I'm not a surgeon. I do some maybe straightforward procedures, but I'm in august company. Thank you.
Can I just pause a minute, because I think people can't see us or hear us, Namu, sorry, which might be quite limiting. Just bear with us 1 second. Just bear with us for 1 second.
I can't see anyone. Can I ask all the presenters and hosts to turn off their camera and turn it back on, please? Sometimes I know there's a bit of glitch with Teams. Apologies about this. So I'm going to do mine as well. Yep, if we can try and turn it back on. Alexis, are you able to turn on your camera, please?
I can see myself now.
Yeah, we can see you now. Yep. Hopefully this has worked, but do let us know in the comment box. Thank you.
So hopefully some of you can, it sounds like some of you can hear us and some can't. So huge apologies for that. Hopefully we'll try and resolve that. So I wonder if we just very quickly go then back to the introductions, just very briefly, just for Magda, then Adrian, then we'll whip round the others on the panel, and then we'll get straight to questions. So Magda, sorry to make you go through that again, but I don't think everyone could hear you. So just briefly to say who you are again.
Hello again, everyone. My name is Magda Smith. I'm a neuroanesthetic consultant. I completed my training in Bristol in Severn Deanery and moved here together with my family in 2017. And I've been a consultant in Addenbrooke's now for 5 years. I mostly anesthetized patients for spinal and neurosurgical procedures. I'm also an audit lead and a quality improvement in neuroanesthesia.
Thank you, Magda. Adrian.
Hello, I'm Adrian Boyle. I am an emergency doctor, so I work in A&E and I've been in Addenbrooke's since 2005.
Thank you. Manj.
Good evening, everyone. I'm Manj Goel. I am a vascular surgeon, so a surgeon dealing with all sorts of blood vessel problems, and I've been a consultant here for 11 years.
Thank you. Alexis.
Hello, I'm Alexis Jannings. I'm a neurosurgeon, so that means I operate on the brain and spine, and I specialize particularly in treating brain tumors and brain fluid disorders, and I've been a consultant for 3 years now.
Thank you. And Erin.
Hello, hi, I'm Iram Amin and I'm a consultant transplant surgeon, and the types of transplants I do are kidney, pancreas and small intestine transplants, and I've been a consultant for 4 years now.
Thank you. Thank you very much, all of you, for introductions. I can see that there's still some technical challenges for some of the audience. I'm really sorry for that. We are trying to work behind the scenes to see if we can resolve that. But I think we will probably continue because a number of you can hear and see us in the audience tonight, but apologies for those of you who can't. So in terms of questions, we've had some pre-admitted questions or pre-submitted questions, which we will start with. But can I ask those of you who do have questions, there's a Q&A button up on your screen, and if you type in there, then we can pick up your questions as we go through this evening, and I can then direct them to members of the panel to ask those. So please go ahead, whatever questions you'd like to ask the panel who are here tonight, and we can start with a couple of questions that have already been pre-submitted. So Erin, perhaps I can start with you, if that's okay. So one of the questions that's been submitted is, do surgeons feel like they're still amazed by what they do, or does it become business as usual?
So I don't think it will ever be business as usual. Each operation has its own unique aspects and challenges. And even though you are doing, for example, for me, even though I'm doing a kidney transplant, no two transplants are the same. And particularly for me, the episode that I was in where we did the living donor kidney transplants, that is something that I will never get tired of, and it'll never be business as usual. To see the kidney being reperfused to become pink after it's very grey, and then it starts producing urine on the table and it starts working, that is just always going to be amazing to me every time I do it.
Thank you. And actually, it was amazing. I remember you describing that when you did the programme. It was absolutely amazing to watch that change of colour from it going to this beautiful pink and healthy colours. It was absolutely fantastic to actually see that on screen as well. So thank you very much for that. Can people just confirm whether they've been able to find that Q&A button? And if you can't, just pop a note in the chat and we can always work through the chat for questions if that's going to be easier. So just to try and make sure that people are able to ask questions. Alexis, perhaps if I can come to you and ask you what's been your most memorable surgery you've performed on a patient and why?
Well, surgeries can be memorable for different reasons, some positive, some negative. I think as surgeons usually like to be optimistic, so we'll leave the negative aspects for here. But usually if you have something which is very tricky or very challenging, and you can have a big impact on one individual patient, I think that is quite memorable. I've had some very large tumors that have turned out to be benign, so you really change the course of one individual from something which is potentially life-threatening to something that is effectively cured. And I think those things stay with you, but equally you also think of things that don't go well, particularly in the context of trauma surgery. Sometimes things don't go well despite your best efforts. So I think a lot of procedures stay with you for their each individual aspects.
Thanks, Alexis. Manj, what about you?
So, I mean, it was extraordinary watching the programme, and I'll slightly answer the question you asked Iram, because that's, what amazes you about surgery. I mean, actually, I was amazed by what some of my colleagues do, because you become so subspecialised that you deal with your own area of expertise almost every day, and it's extraordinary what's happening in the operating theatre next door. And it's so I think it was a really interesting insight for all of us. I think we come across all sorts of very challenging situations, most days, and I think one of the other really important things to highlight was just the team approach to treating patients, and I think that hopefully came across really well in the programme. There are armies of people there to look after almost every patient that comes in. And that's a wonderful thing about what we do. It's the people, it's the teams, it's the combined effort to try and get good results for our patients.
Yeah, no, thank you, Madge. I would echo that. It's absolutely fascinating, isn't it? I've worked in Addenbrooke's for many, many years now, and actually to see some of the amazing stuff that goes on every day that you're just not aware of when you're working in your own clinical specialty, it's actually a real window on a completely different world, and an absolutely fascinating one, and incredibly impressive. So no, thank you very much for that. So I wonder if I can just come to Magda, a question from the public. So one of the questions was, and this is something that I think will be a question that many people will think about, when a patient needs elective surgery, they're told they need to be nil by mouth for the previous 12 hours so they don't aspirate any fluids. If they perhaps have a car accident or some trauma after a night out and they've had a meal, for example, then they need urgent surgery. How do you prevent that aspiration when they've recently eaten and had something to drink?
Yes, that's a very interesting question, and indeed we take as much precaution as we can for elective surgeries. For elective surgery, we advise patients not to eat for 6 hours and not to drink for 2 hours. And you can't do it in emergency. So there is one thing that we can do as an anesthetist, because the most risk of aspiration is just as you're going off to sleep or when you're waking up from anesthetic. During the actual surgery, there is a breathing tube which has a balloon which stops any aspiration. So just those two moments when you're going off to sleep and when you're waking up, we use something which is called cricoid pressure, which is a little bit pressure on the bottom of your neck, and try to stop any fluids coming up just as you're falling asleep. This, unfortunately, it's not 100%, and in lots of major trauma accidents, the aspirations do happen, and patients get chest infections often afterwards. But of course, we can treat it with antibiotics, and lots of multiple trauma patients stay in the hospital for a long time and are treated for chest infections due to aspiration, which might have happened at the time of the accident or even before they came to the hospital, or sometimes during the anesthetic.
Thank you. I hope that sort of gives a really comprehensive view for those of you who are wondering how the anaesthetists and the teams approach that so you can have safe surgery. Thank you very much. Adrian, perhaps I can sort of come to you with a slightly different slant from being in the emergency department. And like all parts of working in the hospital, sometimes we see things that are very challenging and very difficult for staff, for families, for patients. And I'm really struck by some of the absolutely life-changing cases that we saw in the emergency department this time. How do you go from being in that moment in ED with all that intensity to go home and then be part of a family? How do you make that transition? How do you navigate that?
So I think it's important to realise that you've got to worry about it, and it's a human reaction to feel a bit upset by things. And actually, you worry about yourself when you don't worry about things like that, because sometimes they're awful. I live quite close to the hospital, but I make a point of, if I've dealt with something particularly upsetting, I go home slowly and I will hang around in the corridor and have a chat with my colleagues. And there's that peer support that we all have, those corridor conversations about something that's been difficult. So sometimes actually just going home slowly. I think once you get used to that sort of stuff, and then there's a problem, because there's a degree of humanity that's required to look after people well. And once you lose that humanity, I think there's a problem.
Thanks, Adrian. I can see some nods from the other panelists. That really seems to, that resonates, that humanity is an absolute core part of who we are and what we do when we come into work. So thank you very much for that. Aaron, one of the things that I think maybe if I come to you next sort of struck a number of us, I suspect, is that the complexity of the operations and the length of time that you need to concentrate for. So how do you sort of prepare physically and mentally for the length and concentration required for some of the most complex operations?
So I think it's part of it is practice over many years during your training. So as well as doing the kidney transplants, I'm one of 3 surgeons here at the hospital. We run the National Adult Multivisceral Transplant Service. So that's doing intestine containing grafts. So these transplants quite commonly occur over 24 hours or more, and so you are part of that surgical team, which is so there's 3 of us. Either one of us have gone out on the retrieval to get the donor organs, and while the other 2 are at the hospital taking out the organs that need to be taken out, ready to be prepared for organs that come back. So all of it happens over 24 hours. So part of it is making sure that during the operation, when you can, you do have regular breaks. So if you have been operating for a constant 6-7 hours, sometimes you can't stop because the patient is that sick. But the important thing is to have regular breaks during the operation when you can. You hydrate, you have something to eat, you sit down, and then you go back again. So over this 24-hour period, we may have 2 or 3 20-minute, half-hour breaks.
So that's really helpful, because that's a side that we often don't see actually described. How do you sort of navigate some of those real complexities? So really helpful to have those insights. So Manj, maybe a question for you now. In fact, one of the question from the public is, how do we feed back and share, not just within our own hospital, but maybe nationally and internationally, about good practice, and also about where there's opportunities to learn from each other, where things don't always go in the way we intend? How do you do that well? How does your team do that?
It's a really important part of the culture of working in a modern healthcare environment, to have that humility, to have that openness, and to be willing to learn and to change. We've not always been good at that in healthcare. The traditional models of healthcare were that the senior doctors were always right and everyone else just had to follow suit. But I think by regularly monitoring our results, by having national benchmarking, so certainly my speciality, every surgeon doing major operations compulsorily has to upload the operations and the outcomes onto a national publicly available registry. And actually the public can look up individual hospitals and departments to see what results are and outcomes are. And we all learn from each other. If there are hospitals that are doing something particularly well, at national meetings, we make sure that good practice is shared. So, and I think it's really, really important to recognize that and if your department or you as an individual have had a complication or a bad outcome, it's not a failure, and it's actually even more important to recognize and to learn what you can do better next time. So I think it's really important cultural element to it, and it's done very openly. I think the openness is really important.
Thank you. And Iram, is there something similar in transplant? Is there a similar sort of approach?
Yes, so you have a similar approach on a local and a national level. So you have monthly clinical governance meetings which look at cases which have not gone as well as you would like, or would have had complications. And as Manj has said, they're used as learning to see what the positives are from a case, what the negatives are. And then on a national level, you have regular national meetings, and the results from each unit are there for the public to see how you are doing well in each type of organ transplant that you do as a unit.
Thank you, and that's very reassuring, isn't it? Just not just the local learning, but the learning and the sharing, right across both within the UK and beyond, and that capacity then to constantly be doing the best we can based on lots of learning from lots of other people as well as our own practice. So thank you for those examples. Alexis, there's a question for you, and which is, do you find that you get nervous working on patients who are conscious whilst in surgery, and how do you keep yourself calm even when sometimes might not always go the way that you expected?
Well, the first thing that's very important when you have a patient who's awake is you need to have an established relationship with the patient from before. So whilst in some operations, one colleague will see the patient in clinic and somebody else will operate, when you do awake surgery, it's crucial that you have a very in-depth chat with your patient before the surgery, and they know what to expect, you know what to expect from them. And if a patient is particularly nervous, then that's sometimes a potential contraindication for awake surgery. So part of the issue is being prepared. And then within the surgery, there are a number of things we can do if things don't go exactly as planned. And that's not just the surgeon, but in particular the anaesthetist. And in the most extreme of circumstances, you do have to put the patient back to sleep. So we have to prepare all of that from the outset and be prepared to act accordingly. Do you get nervous? I think when you are in that zone of concentration, you have to do what's needed to achieve the best outcome during the operation. So you don't have the luxury to think too much about being nervous, and you just need to focus. But yes, it's all about preparation.
So Alexis, that's really helpful. One of the things, a sort of follow-on question from that is from the member of the public is, so when things don't go to plan, and this might be something for others on the panel as well to have a think about and give their perspective, but when things don't go to plan, how do you navigate that? So when you can get back into the operating theatre the next day or come back in as an anaesthetist to anaesthetize a patient or an ED, Adrian, how do you navigate the difficulties when things go unexpectedly in a way that you never imagined, getting back to doing the job that you do every day? How do you navigate that? So Alexis, maybe if I come to you first, because it sort of follows on from what you described about being in the moment.
So part of it is, well, what happens when they don't go to plan at the time of the operation? And there it's very important to remain calm, contained, and methodical, and just work through things in a very structured manner and say, well, why things not working, and just work through it and make sure that you've not missed anything, you've not misinterpreted anything. And that's something that you need to be very calm. Then afterwards, there is a lot of reflection that's extremely important. In the particular case on the 5th series, I have to confess it was a very suspenseful time until we got the MRI 2 days later, because we didn't know if it was a stroke or it was just a transient problem. So once we had the MRI, which didn't show a stroke, it was a big sigh of relief for all of us, knowing that this will get better, and it has got better. So I think after the operation, you need to reflect. And as we were saying before, and Manj was saying, we need to say, well, how do we learn from things that didn't go exactly to plan? Would we have done things differently? Possibly get another pair of expertise and eyes and say, well, what do you think about this case? So the calling a friend doesn't just happen in the operation, but it also happens afterwards as well.
Thank you. Magda, from a perspective of an anaesthetist, how do you approach that?
As Alexis said, during surgery, we go through things very systematically, and anesthetists are, I think, particularly good at it, because we've got that structure of the ABC drilled into us. So we make sure that the patient is still conscious. And in the case that Alexis was describing, she couldn't talk, but obviously she was still awake. So we went through everything which could possibly happen. We excluded a seizure, a stroke, made sure she's got enough hemoglobin, has a good blood pressure, has a good oxygen levels. And only then we decided that actually we will need to stop the surgery and finish it quicker than expected. And in fact, I did give her a little bit of a sedation to manage the rest of the operation, which was shown in the episodes. And so I think as anesthetist, we've got a very structured approach in the moment. And afterwards, we all talk to our peers. We always discuss all the cases, and both as a sort of hot debrief straight after the incident, but also reflect on the cases later in our meetings, in our morbidity meetings afterwards.
And Adrian, anything different from ED or anything you would add from being in the emergency department?
No, I mean, it's always interesting to hear what other people do, but actually the principles are exactly the same. So we have a monthly clinical governance meeting where we talk about cases that didn't go well. I don't have the privilege of doing the planning. But the way we get around that is by doing an awful lot of drilling and training to get to say, in this scenario, what would you do? And we do a lot of practice, often with simulations, to try and prepare for that sort of thing.
So thank you. So I think, you know, one of the things that you've drawn out lots of times actually already in the conversation this evening has been around that real importance of sharing and teamwork and supporting each other, and how important that is. We sometimes don't talk about it very much, but it actually is a core part of I think working successfully in a hospital, isn't it? That whole team, of which some of you are on the call tonight, but there are others who play a big role in how we work in a hospital. So Manj, just a sort of slightly different question, if I may. So one of the questions that was submitted this evening is, several times I've noted that minor blood vessels have been tied off to prevent bleeding into the operational site. How does the body compensate for this disruption to the circulatory system?
It's a really good question. So the body's unbelievably resilient to. I mean, if you look at some of the things that we do to the patients during operations, the body's unbelievably resilient to a lot of these traumas. And likewise in ED, you know, look at some of the terrible traumas that happen. So there's an inbuilt resilience. So cutting minor blood vessels and damaging minor structures is often tolerated very, very well. In fact, you know, we can even cut through and divide major blood vessels, often with very little in the way of damage or symptoms. Obviously, we try and avoid disruption as much as possible, but there's a lot of resilience, and actually a lot of what we do is almost, you know, during the recovery process is almost get out the way while the body heals itself. So it compensates very, very well in all the specialities that are you know, represented here. And I just wanted to make one of the very, very quick points again, just to reiterate something that we've just said, is the amount of planning and preparation that goes into all these operations is really phenomenal. And there's an old adage in my speciality, which is failing to plan is planning to fail. And so we spend a lot of time preparing, and it's not just the operation if it goes well, but also the contingency plans if things don't go well, because a lot of the challenging parts of the operation are often predictable. And so really to reiterate Adrian's point about simulation preparation, because then if you find yourself in that position, then there is a structure, it's not a completely rabbit in headlights situation. You have some preparation and some thought. So a lot of that happens behind the scenes, and you know, that's a really important part of what we do.
Thank you. I think that's a really important point, isn't it? That where there is an opportunity for all that planning, just highlighting that, because again, you know, actually that was really captured, I think, increasingly in the most recent series about some of the work that went on behind the scenes even before people got into theatre, and that really describes some of what you just talked about just now. Just a sort of quick fire round, if I may. So this is a question that's come up a couple of times. So, did you know what specialty you wanted to go into when you first applied for medicine? Yes or no? And if it's a yes, why? And if it's a no, why did you change your mind? So if I'm just going to go around. So Man, shall I start with you? Because and then we'll just go around the room and see what you say.
Yeah, the answer is no. And I get slightly worried about people who wake up as a child and want to be a brain surgeon or a heart surgeon. I think medicine is about windows of opportunity. And for me, it was a particularly inspirational teacher and an inspirational consultant that I worked with who was a vascular surgeon that really opened my eyes to it. And so I think it's about who you're inspired by and the opportunities you get.
So Alexis, without being too controversial, should I come to you as a neurosurgeon and ask you what you think?
So like mine, I had no idea what I wanted to be when I applied to medical school. I only made up my mind 2 years after qualifying. And again, like Manj, actually your trajectory is very much influenced by key mentors. So I had a mentor who got me interested in neuroscience initially, and then another mentor who got me interested in neurosurgery. So, you know, there are some key people who make an impression, and then the other part is opportunity and serendipity.
Thank you, Magda.
And again, no, I didn't know. And it's partially because not many people actually know what anesthetists do. And when I went to medical school, I didn't even think of anesthetics. was always fascinated by neurology and the neurosciences, so I knew I wanted to do something with that. We were fortunate enough that we could have a 6 months, start 6 months in training in various specialties. So I worked in A&E with Adrian back in 2004 or 5. And I worked with some neurosurgeons as a neurosurgical SHO for 6 months. And only after that experience, it was 4 years after graduating, I decided to choose anesthetics when I had a chance to actually explore other things.
And Iram, what about you?
Oh.
Just on mute, Iram.
So I'm one of those people who wanted to be a surgeon since I was a child. I've always wanted to be a surgeon. I wanted to be a surgeon because in my head, surgeons made people better. And then when I came to medical school, initially, as the others have said, it all depends on the people who inspire you and as you meet. So initially, I wanted to be a vascular surgeon, and then as a medical student I then went out on organ retrievals, and I got exposed to transplant, and from there it was, well, transplant, I get to do absolutely everything. So then it was going down that route.
And Adrian?
So my specialty didn't even exist when I went to medical school. Probably because I'm slightly older than everybody else on this call, but it didn't exist. And so I started training when I left medical school, and I was going to become a cardiologist, and my mother was so proud. But then I went and worked abroad for a bit, and I worked in a country which had emergency medicine as a specialty. And it was that thing of seeing something where there was a variety, where you felt you could really add value. And then I came back, and the specialty was beginning to develop. And it was exciting to join something that was starting.
Thank you. So it's really fascinating to hear all of what made you pick the specialties that you're in, and actually that really describe that medicine's not a straight line. You don't sort of, you know, even from the point you leave being a medical student, actually there are lots of twists and turns and lots of different opportunities, and that through that you find often where exactly what specialty you want to do, and that there is so much choice in medicine. There are so many different parts and so many different areas that you can go into that it can really capture people's interest and imagination, and the importance of having really good mentors on the way through, I think, really struck me from what all of you have described. Take a slight change of tack now. So there's a couple of questions, and particularly related to transplant, but actually I think it'll be interesting to explore that with others on the call, is the impact that COVID had on many parts of the hospital, and particularly on transplant surgery, and what that felt like when you were, and how you navigated that as a team of surgeons.
So I suppose if we look at COVID as a whole, although the hospital was significantly affected by COVID, if we compare Cambridge to London or Birmingham or some of the other major cities, we weren't as severely hit by COVID. And as a unit, we made an active decision not to close, to continue doing transplants, but initially do the transplant in a select group of patients which we thought would be the highest risk of getting COVID or having harm from COVID, whether that be on the kidney transplant side or the liver transplant side or the intestinal transplant side. There were a couple of advantages that we had in Cambridge as being one of the first, or actually the centre in the country that started the SAMBA screening for the COVID test, because all over the country people would have to wait 12 to 24 hours for a COVID swab. We were very lucky in Cambridge that when they were developing and validating the assays, we were one of the first group of people who had access to this. So whereas in the rest of the country, a lot of the transplant units shut down, so all the London units shut down, Birmingham shut down, a lot of the other major cities shut down, we kept our transplant unit open, and actually 2020 was the year that we did the most transplants ever. So we did over 200 kidney transplants. I remember doing the 200th kidney transplant in December 2020. So that year we did well over 350 organ transplants, which was a record year for us. But it couldn't have been done unless we had the support of the entire hospital, from ICU to theatres to the labs to the people who developed the COVID testing, and it was a massive effort by everybody.
Thank you, and it's really good to hear about how much continues, because I think sometimes that's not, we don't talk about that very much, and actually there was a huge amount of work that went on that was looking after patients with COVID, but also other work for patients who really needed the services that were out there. So Alexis, what about neurosurgery? How did...
Well, I wish I could say things were as good as how Iram said, but I would say COVID was a very difficult time, because whilst Cambridge wasn't as affected during the first wave, we were very much facing, well, collectively as a hospital, an unknown quantity. So a lot of the planning and contingency meant that theatre turnover, theatre access was severely limited, particularly when it came to awake craniotomies, because of the risk of aerosol generation. When the lockdown first started, we had a blanket ban on awake craniotomies, and after a lot of convincing, I managed to do the first one 2 or 3 months later. And if you look, the numbers that we did during that year were very low. So I think we did have an impact, and there are still knock-on effects on very large, well, waiting lists for the patients fortunate enough not to have a life-limiting condition. So overall, it was a very difficult period that we had to act as advocates for a patient group and say, well, my patients also need treatment, and compete against other forces when faced with an unknown adversary, really.
Thank you, and it's really helpful to see those two reflections. And I think that struck me in listening to lots of you this evening, and also seeing the incredible work in the programme, is that there's huge complexity in the decisions you make every day around patients and timing for surgery, and all those different things that need to come together, but also how innovative people are to kind of do things differently to sort of maximise the opportunities to make sure the patients get what they need, as close to when they need it, and working as teams to be able to achieve that. Manj, just thinking a little bit around that, one of the questions that was submitted was around one of the episodes related to the patient who had testicular cancer. And the question was, what helps you decide who does what operation? Because there's some operations that look like they could be undertaken by, one or two different teams, or potentially teams working together. How do you decide who's the lead surgeon, or which specialty might take the lead for those kind of operations?
So sometimes it comes down to an arm wrestle. No, I'm joking, so it doesn't really. So there's so much more than the title of a surgeon to dictate their skill level and their experience. And I think this is really, really important. So traditionally, there didn't really used to be separate specialities. There used to be a surgeon who used to operate all over the body, and gradually we're becoming more and more subspecialized. For this particular case, where there was a testicular cancer around the inferior vena cava, there are two priorities, really. The main priority is actually treating the cancer and resecting the cancer. And vascular surgeons, we don't treat cancer at all. So we're very good at dealing with blood vessels, but dealing with cancers and all the specific nuances about making sure you get all the cancer out, that really needs to be done by a specialist cancer surgeon. So in all the hospitals I've worked, the urological surgeons have taken the lead, very skilled urological surgeons like Jim Armitage and Tony Riddick in this episode. But we are always on hand to support when there's some sort of expertise. And I think that's really important, in that any one of us during our operations could come into trouble with an organ system or a body part that we're not super familiar with. But one of the really reassuring things about Addenbrooke's is there is a very, very expert colleague usually down the corridor, so we can call. And one other quick comment about COVID, if I may. It was unbelievably difficult time for decision making. So a lot of the operations we do in vascular are preventative operations. We want to treat aneurysms and other things before they cause a problem. And we were learning very quickly from other hospitals that had a much bigger COVID exposure that if patients were catching COVID after their surgery, the risk of them dying was extremely high. So again, for aneurysm surgery, the risk of dying normally is well below 5% normally. And in some units in the country, that was 60, 70, 80% if they picked up COVID after the operation. And so, you know, we were having to make some very, very difficult decisions about not doing surgery, particularly until the vaccination program came on board, to try and protect patients.
I think that's right, Manj, isn't it? The opportunity for the vaccination program coming on stream has been one of the things that has sort of transformed the ability to think differently again about how we operate and all those decisions, and the complexity, as we said, of those decisions during COVID, which was challenging for so many people. On a slightly different approach, so one of the people who's in the audience tonight has asked, what happens if you, and you may have seen this when you've been supporting some of your doctors in training or some of your teams, what happens if someone chooses a specialty and then realizes quite far down the line that it's not right for them? Is that common? Is that uncommon? Do you support them? What do you do when you come up against that? Adrian, that might be something, you know, maybe you see in ED, and then Manj, maybe something that you see in one of the surgical specialties.
So doctors do change specialties, and it happens quite a lot. And I see doctors who decide to leave emergency medicine, but I also get doctors who get a certain level down their career and decide that they don't want to be a type of specialist and go into another more generalist specialty. And I think actually some of that is actually, I talk to my juniors about what medical school does is teach them the language. But when they start working in a place, it's like living in the country and learning the culture. And you don't really know if you're going to be happy in a specialty until you do a bit of that living in the culture and finding out what it's like. So I'm very relaxed about people trying to make their right decisions. Trainees feel like they train for a long time, but even then they're a consultant for an even longer time. And I'm looking at most of these young consultants, like Magda and Alexis. You've got another 20 years at least of this ahead of you. You may have felt your training was long, but you're a consultant for a lot longer. So it's important to be happy in the specialty that you choose.
Manj, what would you say to someone who came to see you who was quite far through their training and was thinking, having a moment about whether that was the right specialty for them?
It certainly happens. I mean, vascular is potentially quite stressful. We have sadly one of the higher rates of burnout and colleagues with mental health issues because of the nature of some of the work. I think a couple of comments I'd make. So firstly, I think a lot of what you enjoy about the speciality and going to work is fairly generic. We spend a lot of time working with people. We spend a lot of time talking to patients and working in teams. So a lot of that is actually the same throughout the speciality. And often there are things outside work that are affecting someone's happiness at work. But I think we have to be supportive and help people to decide the right speciality for their circumstances, but also to support colleagues who want to change specialities. I mean, we certainly need doctors in all specialities, so I certainly wouldn't put somebody off, but you know, would want to try and help people make the right decision initially, so that they're suited and settled.
So this may feel like an odd question to ask after what you've given both, you know, really helpful advice for people who might be thinking about who are, because it's for some of our staff as well, for people who are in working specialties, whether to do something different. Do you think you're a surgeon for life, or could you give it up? I don't know whether anyone wants to. I'll leave it open to whoever might want to answer that.
I'm not sure I'd know what else to do, Sue. I think, in all honesty, I think we have to remind ourselves how much of a privileged position we have. I mean, people who we don't know very well essentially allow us to do the most invasive things and you know, really put them in a very difficult position. And it's an incredibly privileged position we're in, and also a privileged position working with the colleagues and the teams that we work in. So I love coming to work for now. I don't like the politics as much. We won't talk about that though.
No, but that's that and that kind of is really it's really impressive to hear that have positivity about coming to work. I would say the same coming to the NICU. But Iram, Alexis, other surgical views. Are you a surgeon for life?
Well, I think it's linked partly to the previous question. I was saying, well, you'll train for 10, 15 years and then spend another 30 years or so as a consultant. So it's a long time. And I think doing surgery requires a lot of dedication and devotion to that. And if at any point you realize you're not fully into it, it's never too late to reevaluate. So I think many of us, when we do surgery, we are 100% into it. But if you start having that doubt, it's a very quick, slippery slope, I would say, that you start losing confidence, and then you will take, maybe less complex operation. Things can really amplify. So I think it's very important to always have an open mind. And if that changes, not to be absolute about it and saying, well, what's good for you as a person? And also what's good for your patient. So I think that many surgeons are very much devoted, including myself, but nothing is impossible and you need to have an open mind.
Erin, what about for you?
So for me, I think I am a surgeon for life. As Manja said, I don't know what else I would do. I love my job. I love operating, and you have to really, and as people have said, you need the dedication and you need to love your job, because actually working for the NHS increasingly is quite challenging and hard. There are lots of aspects of it that are very challenging, but at the end of the day, all the positives tend to outweigh the negatives, and so you go home knowing that you've given 110%, and that's what makes it all worthwhile.
Yeah, I think that's right. I think the positives really do outweigh the negatives, and I think hearing you describe your respective jobs this evening and the patients you've looked after and your responsibilities and how seriously and how kindly and compassionately you take them, that really comes out loud and clear from all of you. Magda, what makes you feel proudest about what you do?
A job well done, I think. It's a combination of things. I suppose we're all happy when things go right, but I think we're all proud of what we can achieve, how we can help patients, and how we can help, as anesthetists, we sort of help them go through the journey, the surgeons of course too. We are sort of in a very privileged position to see them at the most valuable. They trust us with their lives, and it's something that it's very important to everyone to sort of recognize that we are very privileged and come in the worst point of their life and get them through the operation, get them through the surgery.
Thank you. I'm going to come to others and ask you in a second, but there was one question that's just popped up that I can't resist asking, because I didn't think about this and I'm cross that I didn't, but I think it's a great question. So how did you feel about the teams in theatre? Did they get the recording teams? Did they get in the way? I don't know whether we should ask that, but anyway, I'm going to go for it. So did they get in the way, and just as valuable for you, Adrian and ED, or were they just blended in with everything else that you were doing?
So I don't think they got in the way. They were incredible. They spent a lot of time hanging around waiting for stuff. And the film crew, they're very nice and they're very chatty. And sometimes I actually had to stop them chatting to my juniors and say, actually, there are patients waiting, go and see people. I don't think they were in the way. They were masters of being unobtrusively. So you turn around and they would be on your shoulder in a way that you hadn't necessarily expected. Now, I don't know what it was like in theatre, because I don't have to work in a sterile environment where things have to be kept very, very clean. But no, I don't think they were in the way. But, from time to time, we get patients getting out phones and filming and all sorts of things. So I think we live in a world where we're used to people taking images all of the time anyway.
What about in theatre for the surgeons amongst you?
Yeah, I'm very happy to comment. So I think anyone who's seen a surgeon concentrating on an operation, there could be bombs going off next door and you wouldn't really notice because you're so focused on what you're doing. So I mean, it wasn't too much of an issue. I mean, we did wear some slightly artificial cameras on our heads to get that sort of bird's eye view. But that was, you know, you get used to that very quickly. And actually, they were very good at managing that environment well. And to be honest, if they weren't good at it, they probably wouldn't be able to do the sort of footage that they do. So it really wasn't too bad. There was a bit of tedious walking up and down corridors, but I won't talk too much about that.
I mean, the visuals that I mean, the filming is phenomenal. When you see it on the end of the screen, for someone like me who doesn't see what you do every day, and say work somewhere else into hospital, what you can see and the detail and is absolutely phenomenal to be able to witness that as somebody. You feel like you're in that space with you. It's incredibly powerful to be sitting in the audience watching that. Alexis, thinking about what makes you feel proudest about what you do. In the final last few minutes, I'll just ask all of you.
I think, as a Maggie, it's the impact of what you can achieve. Sometimes you have even if it looks like a small impact, in most patients you treat, it makes a very big difference to their lives. And I think that has to be the main driving force and what you should be proud of the most, despite some setbacks you can have along the way.
Thank you. And Erin?
I think the thing I'm most proudest of is actually how we all work as a team and how we all work together, and the fact that everybody in the hospital is just really willing to help. If you have a problem, you can go and ask people, and it's very much yes, we can help attitude. And I think that's an amazing work environment to be in.
And just to echo that, Sue, I think it's incredibly humbling to see how the team works in adversity and how the team responds to still deliver outstanding care despite immeasurable challenges. And COVID was one very big example where obviously having major staffing challenges. I'm not wearing a hat, but if I did, I'd take it off to Adrian and his colleagues in the emergency departments. I think there's very few places in the hospital that have had a tougher time than the emergency department the last few years. So I think dealing with adversity is really very humbling, and when it, seeing what people do, it's hard not to feel really proud of that.
Yeah, well, thank you. Adrian, any final words?
Yeah, so I don't get the satisfaction of seeing the end result, but I think one of the things that I really enjoyed in the series was seeing the person with the very nasty lower limb fracture, which is it's not a very complicated injury, but actually I always wonder what happens to them, and actually seeing her go back home and see her look at the caravan where she'd fallen over and broken her leg, and seeing her walking around looking essentially normal, I thought that was amazing, and realizing that we'd all been part of getting her back on her feet.
And some amazing sort of comments in the chat in the last few seconds before we draw the session to go. So thanks to all of you and your colleagues for the inspirational TV episodes. And thanks for all your time this evening for sharing your knowledge, expertise and other insights. I would absolutely echo that. Thank you for all your hard work. Always watch. We're in awe of what we do, because I don't know whether anyone else can see this apart from me. So apologies for reading it out, but I just think it's just a hit, and there's a number of others which just echo those themes. So finally, if I just sort of draw together the evening in the last couple of minutes. So I think what you've just described has been absolutely phenomenal this evening. Amazing things happen here every day, and this series really sort of shines a light on some of the behind the closed doors that we never get to see, and absolutely incredible work that you all do. And of course, I know all of you have said this, but some of it, you are part of a bigger team, and each and every one of you do amazing things, but that's made possible by the teams that you work with. And many of them, obviously, some might be watching tonight, many of them will be busy elsewhere. And I just want to say thank you to them on behalf of Addenbrooke's, to them as well as all of you. So thank you to all of you for your time tonight. I realise it's an evening, and for giving up your time, your hard work, your compassion, your kindness, your insights, your incredible talent has been really impressive to hear what you've described this evening. So thank you very much to all of you for that. And to everyone who is listening and contributing, thank you very much for all your questions. And I hope you found it a useful and enjoyable evening. Thank you.